So it's just great to be up here. You know, this is almost a universe away from where I work every day. The Tenderloin in San Francisco, though it's a very small part of the city, is a very intense part of the city, and really it's remarkable how you can just go 1 or 2 blocks in San Francisco and you get a whole different feel. But I'm really proud to be a health department employee. I'm really proud to be a government employee, and it's just great to be up here to share with you some of the things that this city, the city of St. Francis, is doing better than anywhere really in the United States. And believe it or not, I hope to tell you some stories that can help you leave today believing that here in San Francisco we can be on the forefront of ending homelessness for this country. That my children, I have 2 boys who are 9 and 5, and I hope that they read about homelessness in the history books. And I believe that we are just on the cusp of being able to do that, and I hope to give you some data to show you why we are able to do that. So to start, friends of mine who are lawyers tell me that hard cases make bad policy. And what that means is if you try to create a system in this world where everyone can be under the umbrella, often the system is so brittle that it can't really be sustained. But hard cases also really help to define the limits of what you can do and how far you can go and how you can really find healing wherever there is. So this is a story that's, you know, ripped from the headlines, dum-dum, of a case that was just happening last couple weeks. And some of my colleagues are here and know who I'm going to be talking about. And I want you to know that I take protected health information very seriously, so I got permission from this family to be able to talk to you about her today. So this is a case that is really timely because of the time of the year it is in the Jewish calendar. Tomorrow is the first night of Passover. And for those of you who are aware of the story of Passover, it's all about freedom, right? Freedom from oppression, freedom from slavery. And this is a story of a woman who was able to gain freedom, but perhaps not something else which is maybe equally important, maybe more important, which is liberation. And I've been kicking around those words. I've been writing our Haggadah, which we're going to try to roll out tomorrow night. And the difference between freedom and liberation is just 2 things I just want to put that out there for you to think about as I go through this story and go through the rest of my data for you. What is the difference between freedom and liberation, and which is more important? What do we need to tend to? So this is a story of a 36-year-old woman who has partial quadriplegia since the age of 16. She was in a motor vehicle accident when she was in the back seat of a car driving back from a high school party, and the car had a head-on collision. Other people in the car were not injured, but she had a transection of the spinal cord, complete transection at about, I think, T3 or so, thoracic vertebrae 3. And since this is mini medical school, right? We're going to make this more like medical school. I'm going to ask you some questions and stuff, so you can't just sit there passively like I did when I was in medical school. I'm going to make you participate. No, anyone who knows me knows I never sat around passively. So despite this terrible accident and the fact that the doctors thought that she would never walk again, she had incredible internal fortitude and was able to work with the physical therapist, get out of the wheelchair, and by the time she entered Stanford at 18, she was able to walk with the help of a couple crutches. But unfortunately, that wasn't her only illness that she was going to live with in her life. Beginning around 18, she started to exhibit some pretty terrible mental illness that made it virtually impossible for her to be contained within her home and within her school. She was, the best way I can think of her is like that cartoon character, the Tasmanian Devil. You know, she would just like spin with incredible energies, and everything that would be in her universe would just be spewed to the corners of every room. And that's how she was, and she had to leave Stanford, and eventually she went back to school and finished at Cal. I don't know if that was a step down or step up, but that's what happened. But her illness was really terrible, and eventually her mother wasn't able to keep her safe, and she was conserved by the city of San Francisco, which is hard to do. But often in the work that I do in homelessness, we think if we could only get someone conserved, then we could make things better. Well, we successfully got her conserved, and she went off to a locked facility in 2005, and she was there up until October of this past year, 2011, so 6 years in a locked facility. While she was there, she would have urinary tract infections, skin breakdowns, all sorts of things. And even before she was in the locked facility, she ended up twice in the intensive care unit, intubated on a respirator, because she'd get these sepsis, this bout of sepsis that would just get her so sick so fast. So finally she was released from the locked facility and went out to a board and care, where they just couldn't handle her energy, and they called us up sort of in desperation, and I'll tell you a lot more about what we do in a second, but they called us up and said, you know, you got to find a place for her to live, and we just happened to be opening this beautiful brand new building not far from here in Hayes Valley. So we said, well, this is the best building we have. It has the highest quality mental health services. We can handle her. So she came in, and I was her primary care doctor. And when I first met her, it was just like the Tasmanian Devil. I mean, she had like papers all over the place, things falling out of her wheelchair, you know, a big bottle of 7-Up that she was drinking, a 2-liter bottle of 7-Up, just totally out of control. And she started getting these skin breakdowns, urinary tract infections. Things looked bad. So we had this case conference, and we all got together in the case conference, including her conservator, and her mom came. And I heard all the stories, and for the first time in my career, I said at the end of the case conference, after her mom had left and we were there with the medical professionals, I said, she can't stay in the community. She needs to be locked up. And here was this healthy woman, young woman, 36. And I was saying at the end of this, it was clear to me that sooner or later, something bad was going to happen, and she was going to deteriorate rapidly, and bad things would happen. And we sat around the table, and we all sort of agreed, yeah. And then we left the case conference and we went on our way. So that's the preamble to the story. And I'll tell you what happens later. So how do you define the ideal healthcare intervention, right? So those of us in traditional Western medicine, Jeff talked about my years in family practice in San Francisco General, and we learned that most of the answers are in a pill, right? Come with a problem, take a pill, go away. That's the answer. But what are we trying to do? And when I asked this question of a group of young nurse practitioner students, he said, well, we want to get people's diabetes controlled, get their hemoglobin A1C down to 8.2 or 7.5 or 5.9. Well, why? What do we care if someone's diabetes is under control, right? So, well, why do we do this? What's the point of healthcare? What are some of the reasons that you would think? Why do you want to do medicine? Why? Any ideas? Throw out an idea.
To experience health.
To have health. What's that?
That's it's more than the absence of disease. It's a feeling of well-being, and it's more than physical.
How would you measure that?
Well, I think that can only be measured by the individual, because what is fulfilling and provides good feelings for one person would not be for the other. So it has to come from the individual and their sense of well-being.
So have you ever seen, that was beautiful, thank you. That was really well said. Have you ever read anything like that in the New England Journal of Medicine, right? It's just not there. And so much of what we do is a proxy to something else, to wellness in medicine. And we just miss what we're trying to do out there. And so much of what I do with housing is, I think, much more at the core of what we do in healthcare. So I'm going to tell you a few things. I'm going to tell you about the housing background that we've already established here in San Francisco. I'm going to give you some data on how housing reduces mortality, how housing reduces costs, and how that not all housing is the same, that some housing actually is even better than other housing, which is, of course, better than none at all. So just to start, I want to give you some background on what is going on in this city, remarkable city that we have invested heavily in providing permanent supported housing for chronically homeless, mentally ill, substance-using homeless people. Since I started working in the health department in this area in 1999, we've built now 29 buildings. One building just opened, so I got to keep my slides up to date. Housed about 2,000 people. Initially, we only did renovated single-room occupancy hotels. So those of you who've been through the Tenderloin can see all these housing stock. And these buildings came about because this is a port city, and we built all these kind of crappy, small, 250 square foot rooms. And we went into these rooms and we said to the owners, we'll pay your rent from stem to stern, top to bottom. You retire to Hawaii, and you'll get a check signed Edmund Lee every month, whether the building is fully occupied or not. And the quid pro quo is you have to give us the rate of this building the rental rate below market rate, and you have to renovate it and not charge us anything. So when we go in there, the first thing we do is we pay for rent, and we don't have any upfront costs, which work really well with city government. So we first did SRO, single room occupancy hotels, and I'll show you some pictures. Now we're only doing new buildings. Because with all the housing that's coming into this state, we've been able to compete for these tax credit vouchers. And because we have such great data, we beat out other cities, Los Angeles, Fresno, Bakersfield, to get these state tax credits. And I'll show you some pictures of some really beautiful buildings that all of us would be very happy to live in. Now, the folks we're housing are the sickest of the sick. We prioritize who goes into our housing, and despite our wonderful amount, we still have way more demand than supply. The people who go into the sickest of the sick, so the one-legged schizophrenic with diabetic who has cancer, who's living on a heating vent, will be the most likely person to get in. And I'd love to hear your thoughts if you think that's a good idea. 93% of the people we house have what's called an Axis 1 mental illness. Now, Axis 1 mental illness is schizophrenia, depression, and bipolar, pretty much. So really bad, lifelong mental illnesses. 18% of the people we house are HIV positive. Now, everyone must be part of what's called a third-party rent payee system, which means they get whatever check they get, and if they're an undocumented person and have no government government funding, they pay $0. If they're the upper class of our housing, which is the people who get SSI and have about $905 a month, we take half of their income, first goes to a third-party rent payee, pays the rent, and then they get the rest. Everyone has to agree to that. Sometimes that's a deal breaker for people. They won't sign up, even though I'd be happy to get my rent paid before I go off to, I don't know, do whatever. So this is just a graph that shows what we've done in terms of housing since 1999. Every year we have increased. And remarkably, we have 400 more new units, brand new units that are in the pipeline between now and February of 2013. So not long, we'll have another 400 units. And you can see it started out as renovated SROs, and now it's brand new. This is one of the buildings. Carol Bailey is back there, who works with you all at CPMC, and she used to be the support services director at this lovely building called the Windsor Hotel, and they all have names like this: Windsor, Empress, all those kinds of things. And my health center, which it provides primary care for people, that is on the ground floor. We have about 5 psychiatrists, about 10 primary care providers. We do sort of integrative medicine. The next building, next sort of series of buildings we did, this one's called the Empress All, and this is also on Eddy Street. This is the building that Prince Charles came to visit about 3 years ago, if you were monitoring his whereabouts. This is before his son got married. And I got to meet Prince Charles and Camilla Bowles, which was really fun and scary because there were snipers on all the buildings to protect from him getting hurt. But anyway, he thought this was a good building. He didn't want one of our new buildings. He wanted one that sort of had better sort of grittiness for the photo ops. This was our first new building, which is on the corner of Howard and 6th. That's called the Plaza, and it's 106 units of permanent supportive housing for chronically homeless. I'm going to keep saying this. Mentally ill folks. Beautiful building, and it has solar panels on the roof. It's platinum LEED certified, so it's really amazing building. And just the story, the politics of this story is really interesting, is that when Gavin Newsom was elected, the building was already poured up to the 3rd floor of concrete, and it was supposed to be an affordable housing build-out, which in San Francisco is anyone who makes about $40,000 a year or less can qualify for affordable housing. And he just took it out of the affordable housing pipeline and handed it to the health department as the first new building that we got, and said, fill this up with 106 homeless people. It was a mayoral decision, which, you can feel whatever you can feel about our lieutenant governor, but I'm proud of him and happy that he did that. This building is called Mission Creek, and it's a building that is on Mission Creek, across from Mission Bay, which is beautiful, as you can see. And all these apartment buildings that are around it are $1 million studio apartments. So the guy who lives in that top left-hand corner has been a chronic alcoholic for all of his life. And he pays half of his income to live there. But all around him are people who are in .coms or working over at Mission Bay. And this is what I think makes a city healthy. I think a city, and there's lots of data to support this, that when you have people with means living around people who don't, the overall city is better. And you can look at every public health study around this. And if the gap between the rich and the poor is the smallest, the health outcomes are the best. And this is something that I think we should really strive for, is this mixed kind of housing. This building is owned by Glide Church, and it was the first building that we built with a faith-based organization. It's on Mason Street across from the Nico Hotel. And I was really nervous about this building, and I know you guys had a wonderful fundraiser where you honored Cecil Williams, but I was really fearful that Cecil Williams was going to be calling up the mayor and say, how's this guy on this corner in this building because it's ours? And I was really worried that our ability to really tailor the housing to fit the needs of each individual was going to be undermined by this powerful political system. But to Cecil's credit, never got that call, never would get that call. And this building has more sense of community and more sort of soulfulness than any of our other sites. And then the last picture I think I'm going to show you is this building that we just opened a little while ago called Richardson Apartments on the corner of Gough and Fulton, right behind City Hall. And this houses 120 homeless people, and it's beautiful, right? I mean, this is just incredible architecture. David Baker is the architect. All right, switching gears for a moment, getting back to the Socratic method. This is a slide that has nothing to do with homelessness, but it's something I pulled off the web after I read an article by Malcolm Gladwell. And Malcolm Gladwell told the story of the 2005 oncology national meetings, where Genentech was showing their outcome results from their first big moneymaker drug called Avastin. And this is something called a Kaplan-Meier curve, which is a survival curve. Now, what you want in a Kaplan-Meier curve is you want the intervention group to be separated by some gap, which is shown here by the purple stripes, from the placebo group. So what this shows is that for people with stage 3 colon cancer, and you can't know that because it's not up there, I forgot to tell you, stage 3 or 4 colon cancer, who are given Avastin, after 1 year, the expectation is that 74% of the people who were given the drug would be alive, while 63% of the people who had the placebo would be alive. And after 2 years, 45% of the people who were given this drug would be alive, and 30% of the people who were given placebo would be alive. So a couple of takeaways. It's a bad disease. A lot of people die with or without this medication. With this medication, you have an improved survival. Somewhat. It costs $100,000 a year, and you take it for the rest of your life. When this slide was put up at the 2005 oncology meetings, the entire 2,000 people of the audience stood up and gave it a standing ovation. This was the bomb for medical research. This is a Kaplan-Meier curve of housing versus homelessness. And I'll walk you through it. This was a study we did looking at all the people in San Francisco who were homeless at the time they had an AIDS diagnosis. So to have an AIDS diagnosis, you have to either have a pretty shot immune system and have a T cell count under 200, or have what's called an opportunistic infection, pneumocystis pneumonia, something like that. So when someone is diagnosed with AIDS in San Francisco, we investigate the story of what's happening in their lives at the time when they had AIDS diagnosis, and we found that about 680 of them were homeless when they had their AIDS diagnosis. Now, among those 680, 73 were housed in our program called Direct Access to Housing. That's represented by the red line. The other 610 or thereabouts were not housed in our housing. They could have been housed somewhere else, and they're represented by the blue line. And we matched them by CD4 count, viral load, race, ethnicity, drug use history, age, everything else we could think of, so we had some pretty good retrospective data. Now, there are a couple of very powerful things about this slide. The first part is just looking at ignore the red line for a moment and just look at the blue line. After 5 years in San Francisco, if you were homeless at the time of your AIDS diagnosis and didn't get into our housing, only 25% of the people were alive. Now, this is not before antiretroviral treatment was invented or discovered. This is after we had triple therapy cocktails. And what's remarkable is that if you're homeless and have AIDS in San Francisco, your likelihood of survival is the same as before we had antiretrovirals. So medications have not been able to overcome the co-occurring illnesses of homelessness and AIDS. But if you house them, only 2 of the 73 people died. There will be nothing I will do in my career and I challenge that none of you who are in the healing professions in your career will ever be as powerful an outcome on mortality as housing for people with AIDS. Now, it's not just any housing, it's housing with on-site support services, housing first, which means you move them into housing regardless of their substance use history or their mental illness. They first get housed, and then we make headway on those other things. If you do that in this city with antiretroviral treatment, you can pretty much end death, and if you don't, the mortality rate is dramatic. But unlike Avastin, it's actually cheaper to house people than to leave them on the streets. This is the same cohort of people where we looked at the folks before we moved into housing, represented by the pre-column, and we found that before they moved into housing, they used $50,000 of your taxpayer money for health care services. And after they moved into housing, they only cost about $20,000 of taxpayer money for health care services. While the people who were on that curve heading towards death, not only did they die, but they also became very expensive before they died. And if you add up all the costs for housing, it's considerably less than the savings that you have from moving people indoors. So compared to Avastin, not only does it kick its ass in terms of mortality, but it's actually cheaper. And if you want to make headway in this country on reducing the gross national product from 18% towards healthcare services, to shrink that large piece of the pie that is destroying our schools, making it difficult to have police, if you want to reduce the burden that this country has on healthcare costs, one of the answers is to house homeless people. That will make it cost less, and we will have less money spent on healthcare, which doesn't help them, and we have more money to spend on the things that we think we really want government to do. But we didn't stop there. We looked at some evaluation of that building called the Plaza. In that building, as I said, we had 106 chronically homeless adults. After those 106 people moved into housing, we added up all their healthcare costs before and after they moved into housing, and we found that the reduction in healthcare costs was $3.5 million in the first year after moving in. The cost of the entire program, including an on-site part-time psychiatrist, was $1.1 million. So we saved the government $2.4 million by moving those 106 people off the streets, which is the right thing to do, the morally right thing to do. And it just so happens it lines up with the financially right for a change. Interestingly, not all the people were equally expensive. And 90% of the reduction was among 15 tenants, so-called hotspotters. And I'll give you some data on a hotspotters study. They did not become less expensive to the system until they were housed. And here's the hotspotter study, again, a study among people with HIV, which we have some more robust data on than other populations. In this study, we looked at the 250 people with HIV disease that we moved into our housing. And we set a bar, so an arbitrary bar, and said, let's take all the people among our HIV-positive people we moved into our housing and set a bar at the people who cost $50,000 a year or more. And that will be our study interest, our group of interest to study. It turned out to only be 13% of the total population, which was 31 people out of 250. But they accounted for 73% of the total healthcare costs. And their average healthcare costs, remember the bar was $50,000, so their average healthcare cost was $100,000 a year of healthcare costs for these people. After they moved into housing, their average healthcare cost was $1,819. And there was no significant difference in the housing stability between the high users, the hotspotters, and the rest. Now, is all housing the same? And if you have any questions, if I'm not explaining myself, please don't wait. You don't have to wait to write these down. You just shoot them out for me, and I'll try to answer. This is a study I call Bart Research. It's the study that I can do between Powell Street Station and El Cerrito Plaza, right? So it's not very sophisticated, but I'm going to share it with you anyway because I like it. So what I did is I looked at our 29 buildings, and I just ranked them from most beautiful to least beautiful by my own standards, very scientific, and used these different criteria. Private bath buildings were better than shared bath buildings. New buildings were better than renovated buildings. Nursing services on site were better than no nursing on site, and 6 of our buildings have a full-time nurse. And senior buildings I thought were better than non-senior buildings. And senior in our situation is either 55 years old and older or 62 years old and older, depending on which building. And I just sort of ranked them that way, put them on a list, and then threw in some outcome data on an Excel spreadsheet, Bart Research. And this is what it looks like. So the Windsor, the building that Carol worked in, was one of our worst buildings. And Mission Creek, which I showed you that picture of, is one of our best. And I looked at move-out data as a proxy for quality of service. And you can see that the more beautiful the building, the less likely people are to move out. Now that's pretty obvious, right? I mean, you got a nice building, why move out? But the reasons why people mostly move out is because they're being evicted when their behavior associated with their drug use overflows. So the beauty of the building not only is more aesthetically pleasing, but it also seems to dampen down the behaviors that cause people to have problems that got them to be homeless in the first place. Another Bart Research is I just looked at the mortality rates. And at the Windsor, the mortality rate is 7.6 people a year. About 8 people a year are dying every year at the, 8% of the people at Windsor are dying every year. But down at Mission Creek, only 3%. What's going on? How can beauty of housing impact mortality? What's up with that? What else can you think of where beauty changes mortality? And why? What, take a pill. My blood pressure's better. I live longer. Where's the beauty?
Life is related to quality of life.
Say again?
Quantity of life is related to quality of life.
But why?
Because if your life is good, you want to live, and if your life is crappy, you don't care about living. And so you don't do those things that you need to do to stay healthy.
The will to live?
Yes.
I want to live. A lot of us have had loved ones who've died wanting to live, who had a very strong desire to live, but they died anyway.
But we're not talking about somebody with a terminal illness. We all have a terminal illness. We're all going to die. How long we live is dependent a lot upon how much we want to live, and that is based on a reason to get up every morning with a smile on your face.
But if you're a chronically homeless, mentally ill, substance-using person, and you move into a beautiful housing as opposed to moving into decent housing, what happens to your, ACTH cortisol access that doesn't lay down as much, fatty acids into your coronary arteries and makes you live? I mean, what we do in medicine is we don't say the things you're saying or things that I say when I go to the top of a mountain when I'm hiking in the Sierra or see a beautiful painting at the Museum of Modern Art and I just feel something inside of me that makes me want to live more. We don't talk about that in medicine. We talk about this biology stuff. And it's a lot. I can get so much more traction when I can talk about the cortisol axis than I can talk about.
I think there's a lot of research around music, if we're talking about aesthetics and the human individual response to aesthetics. In terms of visual aesthetics, I don't know. I've never really looked into that, but I think that there probably, I think that there's a physiological response to multidimensional aesthetics.
I think you're right, and but that's all guts, that we know it to be true. Not on mortality. But no, seriously, this is great stuff, and I totally agree with you. I don't mean to disabuse you of your reasoning, but why is it? What is it that's up? It's fantastic stuff. The beauty of art and music, it makes life worth living. And then here we have all these people who we step over as we come out of Bart, who are suffering intensely, and yet we have a solution. But it's not just housing, it's beautiful housing too. You going to say something, ma'am?
Subject tonight is compassion. And my experience is when you sit down and be with whoever for whatever their issue is, and they start to, something stops, something gets quiet, something else can reach in a little bit. I don't think the view outside the window is necessarily what dictates that have some relationship. It's not just medication.
So beautifully said, yeah.
It might allow you to reach the person, but it doesn't necessarily change it.
But what is all that magic hocus pocus you're talking about, right? It is. It's kind of magic, right?
It's in the person that's doing it.
Well, here we have data to show that investing in housing is that kind of powerful magic. That healing
There's a
magic.
package in that housing that you're describing. It's not just physical space, but the physical safeness of continuity, continuousness, and safety certainly can bring
Diana.
something
Yeah.
down.
Hey, Josh.
Yeah, Bill.
The sawtooth
Yeah.
decoration impresses me. And were those lower scores in the less ideal buildings related to anything like more services, or was there something that explained the scores, a couple of which are lower than?
Yeah. No, I think if we did this over a 10-year period rather than a 3-year period, which is what this study was, you would see those sawtooth level out. The sample size in each building is pretty small. So I'm just looking for a trend, and you have to sort of allow to look at the trend line rather than the sawtooth component, because that's, you know, you can have 5 people who happen to die that year because their illness got bad, and that's not going to tell you anything about the quality of the housing. That's why you need this big sample size, which is why we're in such this wonderful position in San Francisco. We have such a big group that we can start to look for trends, despite, like, you just looked at these, you know, 2 buildings next to each other, you might not see this trend. So you have to have a big group. So I think that's important. Jeff?
I'm wondering, Josh, do you have any information about how people live within the building?
Mm-hmm.
Is there anything about relationships that form, or things that would talk about the human quality of interaction that might be relevant?
No, I don't have any measures of that. But I can tell you, I was training a new nurse who was going to help us with access to our buildings, and I walked from the Plaza, which is that really beautiful building, you know, the LEED certified building on Howard and 6th, to the Glide building, which is just across the Tenderloin and sort of on the same street in many ways. You could almost taste the air as different in those 2 buildings. The building that was at the Plaza was, you know, sort of run by a mental health agency, and they're kind of distance and, you know, us and them kind of attitude. And the Glide building, I really think is a manifestation of the soulfulness of the Glide, and you could almost see her, you know, like a cartoon, like her hair kind of got blown back when she walked into this other building. And, you know, I'm sure the data will hold up. No one has moved out or died at 149 Mason. And the Plaza is our worst performing building of all of our new buildings. And I think partly because of that soulfulness. But how would you measure that? I really want to get my hands into that stuff. Of course, New England Journal will never publish it anyway. Anyway, so I'm going to give you one more piece of data before I go on to something else. This is just comparing 2 senior buildings. So the blue is Lanine, which is a senior building in the Tenderloin on Eddy Street in Van Ness, you know, sort of out Tenderloin Heights-ish. And the death rate there is about 6.5% a year. And it's for people 55 years old and older. And Mission Creek is the one in red, and the death rate is about 2.5% per year. And that's for 62 years old and older. Remember, I told you we try to sort the seriousness of the illness to the building. So since we've been sorting, we purposely put the sickest of the sick into Mission Creek and a little bit less sick into Lanine. So if all other things being equal, Mission Creek should have a higher death rate. But just comparing these 2 senior buildings is really dramatic, the difference in the mortality rates based on the beauty. And the services are good in both those buildings. So, yeah, and then Libby.
Yeah, well, I'm thinking of where those beautiful and non-beautiful buildings are in terms of the neighborhood and the behavior patterns of the clients, patients, whoever we're talking about. And if they walk outside of the building on a day-to-day basis into their old habit, it hits them in the face the minute they walk out the door, and they don't at Mission Day, that says something also about supportive environment.
The beauty, I think it has, I mean, my unified theory of homelessness is that trauma is underlying all of homelessness. Physical trauma, emotional trauma, spiritual trauma is a thread you'll find through almost every narrative when you speak to a homeless person. And the treatment, I think, for trauma is safety. So when you have a beautiful building in a beautiful neighborhood, you're not triggering that trauma that underlines the etiology of this illness of homelessness. Just summarizing some of these slides, housing for people with AIDS, PWA, improves mortality, unequivocal. Housing hotspotters, the high expensive people, reduces healthcare costs and can shrink our overall expenditure, healthcare reform or not. We need to invest in housing to reduce our dependency on useless healthcare. Less expensive to be housed than homeless. Quality of housing matters. Well, how do you use healthcare dollars to fund housing services as a healthcare intervention? This is the rub, the policy area, for those of you who are interested in the policy. The savings that I described is in healthcare dollars. The cost of the housing is in city money or in housing and urban development. It's a different silo. And you listen to Sean Donovan, who's the Secretary for Housing and Urban Development, he'll talk about how we need to invest more and more in supportive housing, and he's going out of his way to spend more of his budget towards housing and getting none of the benefit. It's all in Catherine Sebelius's silo. She's the Secretary of HHS. We need to find a way to have the group that's benefiting from these savings pay for them. So here are some ideas. We need to have a prescription for supportive housing, right? You need to find a pharmacy that can fill this, and you need to find a way for the insurance companies to pay for it. Don Berwick was the head of CMS, Centers for Medicaid and Medicare, in suburban Baltimore, a fantastic guy. So I knew I could put his name up there without him being too pissed off. Yes, ma'am.
Have you done any research about the cost savings to the bigger community? So there's a direct healthcare cost due to the residents. But what about, the neighborhoods?
Right. And this was... And this was, there's a building in Seattle called 1811 Eastlake, which was evaluated and had a wonderful article in Journal of American Medical Association, and they did much more of that broad cost analysis and showed, reduction in jail time and in sobering centers and in all sorts of other areas. How would you measure the reduction in sort of badness to the neighborhood? That's more complicated, because if the badness becomes too low, then people with means are going to move into the neighborhood, and then they're going to cost out the rest of the folks who are there. So it gets complicated in terms of that area, but I think we are gentrifiers in terms of moving people into these renovated SROs. Our buildings become a lot less scary when we have on-site services, nurses, doctors, and social workers who are serving people. So here are some just crazy ideas I'm going to throw out there. You can go call your congressman about this one, or congressperson. Walk around the corner to Dianne Feinstein's house. She's right up here, right? Anyway, so the first thing I'm trying to do is connect managed care agencies up with housing providers. So I just got this wonderful federal grant from the Social Innovation Fund. Obama has put out a bunch of different requests for proposals through something called the Innovation Funds, and we won this grant about 2 weeks ago. And in this grant, about $500,000 a year for the next 5 years, which is fantastic. I built in that 50 of the people we're going to house in our new building at the corner of Golden Gate and Leavenworth are going to be from what's called the San Francisco Health Plan, which is the public option for people with Medi-Cal in San Francisco. If I start using too many of these terms, roll me back, okay? This is a whole different area, right? We're going to sort of healthcare economics now. So San Francisco Health Plan has recently taken on the risk of providing health insurance for all disabled people in San Francisco who are poor. They're going to be paying the $50,000 a year for the healthcare services of these homeless people on the streets. So I'm giving them a gift. The first 50 are free. They can take the 50 highest users of their healthcare services and they can get greenlit right into my next housing program. I'll take whoever they got. We will serve them. And what I'm going to do is evaluate the hell out of them to show how much that supportive housing unit saved the health plan by either comparing them with a group in Santa Clara County or by looking at them before and after housing. Or even better yet, if I could get 150 or so, I could even potentially randomize them, though there's some ethical issues there. And then I'm going to come up with a value to the health plan of that supportive housing unit. And I bet you it'll be about $50,000 a year. to give me $10,000, they can have another one, right? And then if I can get $10,000 paid for each supportive housing unit that the health plan wants to house their high users in, I can then ramp to scale and finish this goal of ending homelessness. And it will cost the system less because they'll save that $40,000 a year. But right now, we are tapped out. We have no more city funds to make supportive housing. We need to call on the healthcare sector to pay for this, and it's in their best interest. So that's idea number one. Idea number two is this thing I call PATCH, which is called Program of All-Inclusive Care for the Chronically Homeless. And those of you who know Unlock in San Francisco, a wonderful program, it's a PACE program, or Program of All-Inclusive Care for the Program of All-Inclusive Care for the Elderly. And it's just a higher capitated rate, basically, for those of you following me. PACE programs get about $25,000 a year to take care of seniors who are on their way to nursing homes but can be kept in their home with wraparound services. So it's just a way to use the funding for that. And then lastly, if just someone will give me all the data, I bet I could figure out why people are going into the hospital and being so expensive in the first place. I don't even know enough about why homeless people cycle in and out of the hospital because all these data in different silos. So those are three ideas that are doable today that can move us forward towards ending homelessness. So I want to just put up this montage of these buildings that I mentioned before. And just for a moment, just contemplate, what is it that makes the difference between that building in the upper left-hand corner and the building in the bottom right-hand corner make such a difference on people's mortality and quality of life? How can brick and mortar make such an impact on health? You know, are these the reasons why? Is it safety? Is it cortisol? Is it self-efficacy, self-determination, magic? What's going on? I don't have those answers because they didn't teach this to me in medical school, but I think you have these answers. Many of you have articulated many of these answers before, and you know it in your gut. So getting back to that last bullet, freedom versus liberation, brings us back to the story I started you with. So she died 2 weeks ago. She was found in her room, unconscious on the floor. She didn't come to pick up her medications that the nurse was supposed to give her that morning. She was brought by ambulance actually to CPMC, put on a respirator, kept her there for a couple days until her family could gather from around the country and they were by her bedside. They turned off the respirator and she died. It's a cautionary tale, and I'm not particularly pleased that I predicted this outcome. But what do we learn from this story? Her mom called me up a couple days after she died and she said, you know, thank you so much for giving her the freedom she had in the last 3 months of her life. I have no doubt that she would have preferred to be out of that locked institution and died than to still be in that locked institution. She had freedom, but she was not liberated from her mental illness and all the other demons that she had in her life. So while housing can provide this incredibly important thing that we repeat our story in Passover every year to talk about the importance of freedom from slavery, and we remind ourselves of that incredibly powerful thing that we all need to hold at great value, it's not enough. And I think that medicine sort of has run up against a boundary where we can perhaps do freedom, we can perhaps do health, but we need to do something else as well. And I think that's where I want to leave you with, to think about what would that be? And how could we help people who are living with so many demons, whose many times their choices, which are their own and where autonomy needs to be honored, their choices lead them to ill health. And which is more important, freedom or health?